Chest pain is one of the more common reasons for patients to present to the emergency room. And so there are different diagnostic tests that are going to be undertaken, starting with the ER physician, and that may progress to actually being admitted to the hospital. One of the first things that the emergency room physician is going to do is he's going to order an EKG. What an EKG does is that looks at the electrical activity of the heart. If you're having poor blood flow to the heart, that's going to be reflected as abnormal electrical activity, which you can see on the EKG. Now, the purpose of this is not to teach you how to read an EKG. This is really just for patient education, so I'm not going to get into the weeds about the EKGs, but just be aware that there are certain changes that we look for that can indicate that you're having decreased flow or even having an overt heart attack. Laboratory testing will be part of the workup for heart disease. The test that we use these days is called a troponin. That is a protein that's found in heart muscle cells. If there is damage done to the heart muscle itself, that will cause the cells to die, and they release all their stuff into your bloodstream, including the troponin protein, and then we can measure that in the lab. And what we are really interested in is we of course have a normal range for the troponin, so it's concerning if you're ever outside the normal range. But what we're really interested in is there a change in your troponin levels. It's concerning if your initial troponin was here and your second one was here, but it's also concerning if your first troponin was here and your second one is here. Again, we're looking for any significant change between the first and second and possibly even third troponin. The troponin is relatively specific to the heart muscle, so it's a good test, but I do have to say I think we check way too many of these in most emergency rooms, and so we wind up with an awful lot of positive troponins, and many times those patients will go on to have negative workups, but it is an important tool. If your workup in the emergency room is concerning, the emergency room physician will likely request that you be admitted to the hospital for further testing. So that will usually always include a exercise stress test. We have different ways of exercising the heart. If at all possible, we would like to have the patient walk on a treadmill. But if the patient is not able to do that for whatever reason, we also have different medications that we can use to stress the heart. And while we're doing the exercise stress tests, we're doing repeat EKGs, and again, we are looking to see if we can induce any EKG changes as we exercise the heart. Nuclear testing has become a fairly routine part of cardiac testing, and what we're doing with nuclear testing is we are injecting a radio tracer into your bloodstream, and that tracer is taken up by healthy heart muscle cells, and then we can take a picture of it. So with the stress testing, what we're doing is we are injecting the radio tracer while you're at rest, and we take a picture, and then we stress the heart and take another picture. And what we're looking for is a difference between those two pictures. If we have a heart muscle cell and we inject radio tracer into your system, if the heart is healthy, we expect it to be diffuse uptake of the tracer in the heart muscle. And again, this would be our resting scan. And then we stress the heart and we take another picture. And if the heart muscle is healthy, we expect the resting scan and the stress scan to look the same. But if you have poor blood flow to the heart, what we will see on the stress scan is you will have an area where the radio tracer is not taken up. So again, we have a defect here that was inducible. It was induced by stress. So that's an indication that you have you have coronary artery disease, poor blood flow to the heart. Now, if you're somebody who has had a heart attack in the past, you might see that same defect on the resting scan. Again, you had a heart attack in the past, so that defect is going to be on both sections. Now, you may have poor blood flow to a second part of the heart. That's certainly possible, in which case you might see an additional defect up here. So again, what we're looking for is a difference between the resting scan and the stress scan. Another diagnostic test would be a stress echo. We actually don't do a whole lot of these, but occasionally we do. And in a way, it's similar to the nuclear scan, but what we're doing is we're doing an echocardiogram while you're having the stress test done, and we're looking for any abnormalities in contraction of the heart muscle. If there are any significant abnormalities on the stress test, the nuclear testing, or the stress echo, that will likely prompt consultation with a cardiologist to perform a coronary arteriogram. Now, what's happening with that test is they are taking a dye and they run a catheter actually up to the heart muscle, and they're squirting this dye directly into your coronary arteries and taking pictures. And what you are looking for is a narrowing in a part of one of the coronary arteries. The thing about that type of testing is not only can it be diagnostic, but it can also be therapeutic, because if they see a significant blockage at the time of the arteriogram, they can use balloons and stents to then open those vessels up. Now, sometimes the nature of the lesions are such that we do not do balloons and stents, but rather you have to be referred for bypass surgery. But more times than not, if they find a problem, they can address it and fix it while they're there. The coronary arteriogram is actually the only test that we've talked about that actually looks at the coronary arteries. So it really is a definitive test for significant coronary artery disease. But it's important you understand that the lesions that an arteriogram is going to detect it's those lesions that are high grade enough, number one, that we can actually see on an arteriogram. And a lot of times that is the lesions that may be causing you to have angina. It is not necessarily the lesion that may ultimately cause a heart attack at some point. And so that's why sometimes, unfortunately, patients will come in and have diagnostic testing. Everything looks great, and they come in the next day with a heart attack. And that is because the lesions that actually result in a heart attack are sometimes not the high-grade lesions that we find on diagnostic testing, but rather a smaller lesion where you have a plaque that is unstable and that plaque ruptures. And it's that plaque rupture that results in an acute event. And again, that's unfortunately, it's just not a good way to pick those lesions up. But again, if you're having significant issues with chest pain, be sure to, there's really nothing you can do other than show up in the emergency room, but all of these diagnostic tests are what you can expect.